approach a patient with young stroke? Because as we all know, a young stroke is very common, and it is seen that almost 15% of the stroke which occurs are mainly in the young. So it's getting more and more common, and especially in our region, that is the Asia Pacific region, the young stroke is quite more prevalent, the cause being not known. And so we need to know this entity properly, and the approach to young stroke is a bit different from that of the routine strokes. So I'll start with a very brief case, which I saw almost 2 years back. So this is a 9-year-old boy. He's from Asansol, which is a nearby city. It's a nearby city to Durgapur. It's a 5 days history of sudden onset of weakness of the left upper limb and lower limb with facial deviation to the right. So this was the history which he presented. There was no past history of migraine, no history of headache, trauma, or any other systemic symptoms or features of any systemic infection. The family history was normal. On examination, head to foot examination was normal. There was no any stigmata of any systemic disorder. And the cranial nerve examination, fundus was normal, no evidence of any vasculitis. And there was a left mild UMN facial paralysis and grade 3 power in the left upper limb, grade 4 power in the left lower limb with mildly brisk reflexes and upgoing plantar on the left side. So he had a classical left hemiparesis, a very young boy, 9-year-old, with no other systemic illness and no significant past history. And rest of the examination, the pulse was normal. There was no atrial fibrillation or any cardiac pathologies in auscultation of the heart. So this is the MRI scan. And as we all know, this is the T2 weighted image. You can see the CSF is white. So this is a T2 weighted image. And gray matter is dark and white matter is, the white matter is dark and the gray matter is gray. You can see here. So there is a large hyperintensity involving the caudate nucleus, the basal ganglia. This is the basal ganglia this is the caudate. This is the basal ganglia, which concludes of the putamen and the globus pallidum. And then you are having this is the external capsule. So there is a large lesion, hyperintensity involving the right side of the basal ganglia and the surrounding areas. And if you can see here, the blood vessels are quite prominently seen in the left side, but here it is less. So probably there is a occlusion of the middle cerebral artery involving the right side, and it is not a complete stem occlusion, because if it's a complete stem occlusion, the infarct would have been larger, involving the whole of the MCA territory, but it's not involving the whole of the MCA territory. So it's probably a deeper branch involvement, probably M2 or M3 involvement. But the size of the infarct is large. There is some mass effect is also seen. So this was the initial presentation. So young stroke, I had to evaluate the patient. This is the hemoglobin, this is the ESR, and this is the CRP. Everything is normal. There is no inflammation. Renal functions, liver function tests are normal. Peripheral smear was done, which did not show any abnormal cells. Sickling test was done because there are a few cases of sickle cell anemia, which is seen in this region. And we did a 2D echo, which was normal, and ECG was also normal. The echo was repeated by an experienced cardiologist, and no cardiac abnormality was found. The thrombophilia testing we planned for the protein C, protein S, and the entire thrombophilia profile. But because the patient was from a very poor background, so we could not do the thrombophilia testing here. Now, because he had a very young stroke, so I wanted to evaluate the vasculature. So a DSA was done. So this was sent to a higher center because they could not afford DSA in a private setup. So we had sent the patient to the Apex Institute in Calcutta, and the DSA was done in the government setup. And you can see there is a occlusion involving this is the ICA, internal cerebral artery. This is the MCA, and this is the anterior communicating artery, and this is the ACA. So you can see there is good flow here. You can see a lot of collaterals here, and the other branches are beautifully seen. But in the right ICA, you can see there is a complete occlusion of the right ICA, and the MCA branches are not seen, and there is no collaterals as well. So there is a occlusion involving the right ICA. This is the posterior circulation, And you can see this is the vertebral artery, this is the basilar artery, and this is the PCA. And this you can see the posterior communicating artery. So all are well seen. So there is a stroke involving the middle cerebral artery, and there is a vascular occlusion here. So, and you can see the arch is quite okay. There is no occlusion in the arch. So this was the radiologist there and the neurologist. This was reported by them, and I discussed the case with them. So they had written it like a unilateral moya-moya disease, or it was a focal angiopathy of some type which was affecting the blood vessel. A neurosurgery opinion was also done, and they felt that it was unlikely to be a moya-moya disease because the entire ICA is getting occluded. Usually in moya-moya, what happens is the distal branches, that is the MCA and the circle of Willis, gets affected, and there are a lot of collaterals all about, and there's a puff of smoke appearance which was not seen. So neurosurgeon and everyone felt that it's unlikely to be moya-moya, and probably some sort of a focal angiopathy which has occurred. And so we went forward with conservative management only. No intervention was done, and the child was started on aspirin, and he came for follow-up twice or thrice, and after that he's lost to follow-up for last 1 year, and with a diagnosis of focal cerebral angiopathy, and aspirin was continued. There was improvement in the motor power gradually, and he was able to walk without support. Some distal spasticity and some distal weakness was there. Apart from that, he was quite well. So this is a prototype case in the pediatric age group of a pediatric stroke, which we often come across in our clinical practice. Now here, if it was a moya-moya disease, which can again present with similar manifestation, then usually the neurosurgical interventions are required, and vascular intervention is required for the management. But in this case, we went for conservative management. So this is just a small example of the cases which we may come across in the younger age group. And then it becomes difficult because a pediatric child or a pediatric age group, when somebody comes with a focal neurological deficit, then thinking of a stroke is the last possible diagnosis which we would like to consider, because pediatric strokes are not very common. So you have to keep into mind that even strokes can occur in the very young age group as well. Now we all know the stroke in the young is divided as brain ischemia and brain hemorrhage as in the elderly age group. And so ischemia can be due to thrombosis, can be due to embolism from other site. Embolism can be of two types. One is artery to artery embolism, and second is a cardioembolic disease. And then systemic hypoperfusion. So if there is a hypotension and if the collateral flow is not very good, then there can be watershed infarcts, especially in hypoperfusion. So this watershed infarcts can occur in the major blood vessels like the ACA, MCA watershed zone or the MCA, PCA watershed zone, or it can occur in the deep penetrating artery watershed zones also. So there are two watershed zones which can, the infarction can occur. So that we have to get the history of a hypotension or low blood pressure, which may have give rise to the watershed infarct. Then brain hemorrhages, we all know intracerebral hemorrhage or subarachnoid hemorrhage. So in this session, like we'll not be going into details of the intracerebral hemorrhage. So mainly of the ischemic stroke and some bit of intracranial hemorrhages will also be discussed. Now brain ischemia, I've already mentioned. Thrombosis can occur. So thrombosis refers to local in situ obstruction of an artery. So the obstruction can be due to the disease of the arterial wall, like arteriosclerosis, or some atheromatous plaque which ruptures, and there's unstable plaque which ruptures and gives rise to occlusion, like in the myocardial infarction. Or it can be due to dissection of the arteries, or some conditions like fibromuscular dysplasia, etc., which can give rise to thrombosis, or some vasculitis, which is giving rise to inflammation of the blood vessel and thrombosis. So any etiology, be it atherosclerosis, vasculopathy, vasculitis, everything can give rise to in situ thrombosis and a stroke. Now embolism. Embolism is originating from somewhere else, and then it gets embolized to involve the blood vessel. So the process is not local in embolic. And hypoperfusion I've already mentioned. Now this is a very busy slide. I'll not go into the entire details. Now this is the pathophysiological classification of stroke. So you can see the stroke can be divided into large artery large vessel atherosclerotic stroke, which I've already mentioned. These are the sites of the atherosclerosis. Usually it's in the bifurcation of the common carotid artery or the carotid siphon. And the less common sites are also mentioned here. Then comes the small vessel lacuna stroke. And the mechanism here is different. It is lipohyalinosis, not atherosclerosis. And sometimes atherothrombosis may also be there. And most common location is in the penetrating branches. So it occurs in deeper areas and the size of the infarcts are smaller in size. So that constitutes the lacuna stroke. And then you are having a huge group of cardio-aortic embolic disease. So either the embolism can be from the heart or it can come from the arch of the aorta. Now, arch of the aorta, if there is a more than 4 millimeter plaque involving the arch of the aorta, then that can give rise to an atherothrombosis. So it's a very important site of atherothrombotic stroke. We must remember that we look for everything. We look for the heart, we look for all the things, but we often miss the arch of the aorta. So you have to do a proper angiogram right from the arch to the vertex. So it's called as the arch to the vertex angiogram, CT angiogram or DSA. And the arch of the aorta should also be evaluated, especially when you see that the carotids are normal and the internal carotid artery, the other distal vessels are normal and the heart is also normal. And when you are not getting a focus of emboli, then always look for the arch of the aorta, because there may be plaques there which may be missed in a normal Doppler or some other investigation. So these are the various causes, and I'll just brief in the heart disease, we should know that some lesions are more prone for cerebral embolism, while some are less prone for embolism. So, yeah, what are the lesions which are more prone for embolism? Most important is atrial fibrillation. We all know that. So any stroke patient, young patient or older patient, first thing is we have to rule out a atrial fibrillation. Now the AF can be a persistent AF or a chronic AF, or it may be a paroxysmal AF. Paroxysmal means transient AF. So in that case, we need to do a prolonged Holter monitoring to get a paroxysmal AF. Then there may be other abnormalities like left atrial thrombus, left ventricular thrombus, sick sinus syndrome, AF, and a myocardial infarction within the past 1 month. Mitral stenosis is very common in our part of the world. Mechanical heart valves, and a MI with a low ejection fraction less than 28%, or a DCM with a low ejection fraction of less than 40%. So this values you should remember: less than 28 in chronic MI, or DCM with less than 40%, and non-bacterial endocarditis, infective endocarditis. So these are the commoner lesions which can give rise to AF. So if you find this lesion, there is a high chance that the stroke is cardioembolic. Then less chances of stroke can occur with mitral annular calcification, PFOs, atrial septal aneurysm, and atrial septum aneurysm with PFO. So these things, wall motion abnormalities like hypokinesia, echinesias, other than apical echinesias. Now, apical echinacea gives rise to more chances of embolism, while other wall echinesias are low risk lesions. Hypertrophic cardiomyopathy. So if you get this in the echo scan, then you know that it is likely to be a low risk lesion. While if other lesions are there, then you think that it's a high risk lesion. So this has to be known. And then the aortic source of embolism. So if there is a complex atheroma in the ascending aorta or the proximal arch, more than 4 millimeters thickness, or if there is mobile debris or plaque ulceration. So if you get any one of this, then you should know that the aorta may be a major source of embolism. Okay, so we'll just go to the TOAST classification. So this is the basic classification of stroke. It's known as the TOAST classification. So it classifies the subtypes of the acute ischemic stroke. As I've already mentioned, large artery atherosclerosis. Second is cardioembolism from the heart. Then small vessel occlusions. Then there are types like stroke of undetermined etiology. You evaluate the patient, you do everything, you do the angiogram, you have done the echo, you have done the ECG, everything is normal. So it's said as stroke of undetermined etiology. And there is one group where there is stroke of other determined etiology, like some other disorder, like hematological disorder or some vasculitis or some TB meningitis or some herpes vasculopathy, so which is giving rise to stroke. So that is stroke of other determined etiology. And undetermined means despite of all the evaluation is negative, or you are getting two or more causes of the stroke. So multiple causes identified, you don't know which is giving rise to the stroke. Or if the evaluation is not perfectly complete, so you are not able to do a CT angiogram, you have just done a Doppler, you are not able to do a transesophageal echo, you have just done a transthoracic echo. So in that case, the evaluation is incomplete. So in that case, again, you have to say it's a stroke of undetermined etiology. So this is the broad classification of the stroke. Now, this is a very complex slide, and I will not go into the details of this. It's not required at a basic level, but few things I'd like to just highlight. So whenever you get a large artery atherosclerosis, you should look at the occlusion of the blood vessels, the major blood vessels. So if it is more than 50%, at least there should be a occlusion. Then only you can say it's a significant, or if it is less than 50%, there should be some plaque ulceration or thrombus which is seen in that. And there should be history of a Amaroxus phoebax. So that is called as TMB, transient monoocular blindness, or stroke in the area of the atherothrombosis, previous stroke. So if you get this pattern, then you can correlate that likely the atherothrombosis is giving rise to the stroke. Second is a cardiac aortic disease. Now, cardiac aortic disease, there should be evidence of a high risk cardiac source of cerebral embolism, which I've already mentioned. Either a MS, either a AF, or either a left atrial thrombus, a low ejection fraction less than 28% in a MI, or less than 40% in a dilated cardiomyopathy. So if infective endocarditis. So all these things, it's a high risk lesion. So if you get a high risk lesion, that is okay. And if there is evidence of other systemic embolism, suppose if there is a patient has an emboli involving the distal hands or the feet, and there is a dry gangrene which is getting up, so then you can say it's a cardioembolic stroke. And there should be multiple infarctions in involving multiple territories. So it should be right, left, anterior, posterior circulation. So multiple circulations are getting affected, and there should not be evidence of any major blood vessel occlusion. So then only you can say it's a cardio-aortic embolism. Now coming to small vessel occlusion, they have given the size of the lesion. So the size of the lesion should be less than 20 millimeters, and it should be there in the perforating artery territory. So in the basal ganglia or in the brainstem, such areas, the infarct should be there, and it should be smaller in size, and there should be no major occlusions in the blood vessels, and there should be no evident cardiac sources of the embolus. Then you can say it's a small artery occlusion. So these are the various criteria we should know whenever we get a patient with stroke. And in young stroke, it becomes very pertinent that rather than just writing a ischemic stroke or a hemorrhagic stroke, you should always try to write about the mechanism of the stroke. So whenever you write the diagnosis, the third point is what is the type of stroke? First, what is the territory involved? Third is what is the mechanism of the stroke, whether it's a large artery atherothrombosis, whether it's a cardioembolism or cardio-aortic embolism, whether it's a small vessel occlusion, or whether it's an undetermined cause, or there is some other specific cause like vasculitis or something like that. So always try to write the mechanism of the stroke. So this is called as the mechanism of stroke. And the mechanism of the stroke you can make out by looking at the pattern of the infarct, the territory which is involved, what is the pattern of the infarct, and you have to look at the blood vessels, the vasculature from the arch to the vertex, and also the heart, and also systemic features wherever it is required, systemic evaluation, hematological evaluation, vasculitic evaluation. So putting all together, you can know about the mechanism, what is giving rise to the stroke. Okay, so there is a term which has to be introduced, and I think everybody should know this. It's called as a sorry about that, some problem happened. So is this slide visible?
Yeah, visible.
Okay. So it's called as a embolic source of undetermined significance, or ISUS. So it's quite coming up, and with the advancement in the investigations, the ISUS or the cryptogenic stroke, if you can say it may probably a type of cryptogenic stroke. So ISUS, they have like there is some criteria which can tell us like it is an embolic stroke, but we are not able to find out the origin of the embolus. So in the scan, CT or the MRI scan, it should not be a lacunar stroke. So stroke size should be larger. So they have given a dimension of 1.5 centimeter in the CT scan or 2 centimeter in MRI. So it should be larger than that. And there should be not more than 50% luminal stenosis of the major arteries. And there should be no cardiac high risk lesions and no other specific causes like vasculitis, dissection, migraine, vasospasm, or drug abuse. So if you exclude all this, and if you're having a large infarct in the MRI, which is more than this size of 2.2 centimeter in MRI and 1.5 centimeter in CT, in a distribution which is not in the lacunar territory, then you can say it is likely to be a ESUS. So this terminology also has to be remembered. Now, what are these stroke mimics? Now, stroke mimics means the conditions which can mimic like a stroke. So in the young age, even the stroke mimics are more common than in the elderly age group. So the most common stroke mimic which we see is a migraine with aura. So sometimes a migraine can have sensory symptoms in one part of the hand, feet, and the face. So it may look like a stroke, and it is usually followed by headache and other symptoms. There may be past history of headache. So if we take a proper history, we can definitely find out whether it's a migraine with a aura. Sometimes the migraine can have complications like a stroke. So a stroke may occur in a patient with migraine with aura. So that also has to be kept into mind. Then Todd's palsy. Suppose there is a structural lesion in the brain on one side, and the patient develops multiple episodes of focal seizures. So if there is multiple episodes of focal seizures, suppose right focal seizures many times, then what happens is after the seizures, the part of the brain where the seizures occurred, there is a edema formation. And because of that edema, the patient will go into a paralysis-like thing. So it's called as a Todd's palsy. And gradually when the edema subsides, the paralysis improves. So the Todd's palsy may also look like a stroke. So you may ask the history of similar attacks in the past, whether the patient has a scan before. You can look for whether there is a fixed lesion there, some scar is there, some old history of trauma, old stroke. All this can give rise to a Todd's palsy. So that you have to look for. Sometimes a tumor, intracranial space occupying lesion, can look like a stroke. CVT is a type of venous stroke which can again present with hemiplegia, headache, papilledema, and seizures. Functional deficit, very important. Young patients, female patients, young patient with depression and other things may suddenly exactly mimic like a stroke. So then you have to evaluate the patient, take the history, find out there is a stressor before the stroke-like episode. Ask the history whether there is a stress or something which was there before the onset of the symptoms. And also in the functional patient, you can see that usually the face is paired and they will give a fluctuating weakness. So when you try to ask them to hold, so they'll give some giveaway weakness. So initially you'll feel that the power is there and then they will suddenly let go. So that's called as a giveaway weakness. So with that, and then plantars, you can examine the reflexes may not be asymmetrically increased, but it may be quite difficult sometimes to see, to find out whether it's functional or not. So then it's better to investigate and do the scans of the brain to rule out a actual stroke before we say it's a functional disease. Then head trauma, then mitochondrial diseases. These are quite rare. Subdural hematoma, definitely you should not miss, especially in an elderly patient. Subdural hematoma can present with acute neurological deficit. And it's very important to know, because if the patient presents with symptoms, you may, thrombolysis is contraindicated if there is a subdural hematoma. And sometimes the hematoma may be iso-intense in the CT scan, so it may be missed. And some hematomas may look like the brain parenchyma itself, and so it may be easily missed also. So you should have a high index of suspicion to rule out a subdural hematoma before you are going to thrombolize the patient. So these are the major things. And one more thing is hypoglycemia. So any patient with hemiplegia, you should rule out a hypoglycemia, especially diabetic patients on insulin and all. Now, what is coming to the topic proper? What is the definition of young? So I went through many papers and publications, but none of them defined what is the definition of a young stroke. So usual age, what I could find is 15 to 45 years, maybe up to 50 years, some patient mentioned. So above 45 years, you can say it's a young stroke, and lower limit is 15. Below 15 is a pediatric age group stroke. And this I've already mentioned. It can be ischemic, it can be hemorrhagic, and venous stroke is also common in the younger age group. And etiology, pediatric, young women, and pregnancy. So these are the special groups which can occur, especially in the pregnancy, the strokes, postpartum and the intrapartum period. There's many different types of strokes and different etiology may occur, which we should be well versed with. Now, why is it important to know about young stroke? We should know that the current epidemiological data suggests that 1 out of 6 strokes are in the young adults, and up to 15% of the cerebral infarcts are occurring in the young. So it's a very common disorder, and it has a etiologic diagnosis which requires a different and more complex diagnostic workup. So unlike a elderly patient who comes with stroke and is a diabetic, hypertensive, and he has all the risk factors, you need not do a very extensive workup. But when you get a young stroke, you are worried because you do not know what is the underlying disease which is giving rise to the stroke. So the workup becomes quite intense and very taxing, and you got to do all sort of investigations to try to find out what may be the underlying etiology. And the management may be different because the underlying cause may be different. So if you're getting a vasculitis, you have to manage with immunosuppressant. If you're getting a tuberculous meningitis, you have to manage with ATT. So the treatment is entirely different depending upon the cause of the stroke. If you're having a moya, you have to revascularize the patient by doing an intervention. So there's a huge difference in the management of the classical stroke and a young stroke patient with a different diagnosis. Now you should know that these young people, 15 to 45, are the most productive age group of the society, and this stroke may have a huge economic impact, not only in the family, but also in the entire nation. But the good thing is that the prognosis is good and the recovery is also good because these people are young, comorbidities are less, and the neuroplasticity is also very good. So these patients recover quite well. And it may be a forerunner or initial manifestation of catastrophic disease. So very severe disorders can present with a stroke-like presentation. So it becomes of paramount importance that we try to diagnose the condition to predict the prognosis as well as to make out the right treatment path. Now, etiology on the young stroke can be ischemic, which I've already mentioned. Ischemic stroke, large artery stroke may be there. There can be premature atherosclerosis. Dissections can occur, especially it can be traumatic and non-traumatic as well. Inherited metabolic diseases can occur. Collagen vascular diseases like fibromuscular dysplasia may affect the blood vessel wall. Vasculitis can affect. Moya disease can occur. Radiation-induced vasculopathy can occur, and then drug-induced. Especially in the young age group, you should always ask history of addictions, especially cocaine and the various heroin and various drugs which the youngsters take. They may all give rise to stroke. Both ischemic and hemorrhagic strokes are well known. So always ask history of addictions, IV drug abuse in the patient with young stroke. Small vessel diseases, vasculopathy, cardioembolic disease, which I've already mentioned, rheumatic heart disease, congenital heart disease, arrhythmias, endocarditis, MVP, PFO, atrial myxomas, and cardiac surgeries and procedures you should know. And hematological diseases are a very important group which can give rise to stroke. Especially in some areas, sickle cell disease may be there. Leukemias can present with stroke. Hypercoagulable states. So there are a lot of hypercoagulable diseases, protein C, protein S, antithrombin 3, APLS syndrome, factor V Leading deficiency. So this can all give rise to young stroke. DIC, thrombocytosis. Polycythemia is an important cause of young stroke. And TTP, thrombotic thrombocytopenic purpura, and then venous occlusions can occur in the hematological diseases which can give rise to stroke. And finally, migraine is also a uncommon but important cause of young stroke. Now, hemorrhagic stroke, I'll not be going into the detail of this. Subarachnoid hemorrhage, we know cerebral aneurysm. So aneurysm rupture is an important cause. And intraparenchymal hemorrhage. So in the elderly patient, what we see intraparenchymal hemorrhage is usually due to two major causes. One is a hypertension and second is a amyloid angiopathy. But in the younger age group, it can be due to AV malformations. It can be due to neoplasms, which can give rise to bleed. Hematological disorders like sickle cell, etc., can give rise to bleed. Moya disease, we all know, in the initial stages, it will give rise to infarction, and later on it gives rise to bleed. So that is a thing. And then drug induced, all the antiplatelet drugs many of the patients are on dual antiplatelets. Then warfarin, the newer Novax, newer oral anticoagulants, all this can give rise to bleeds. And peri-procedural bleed. You should know that the amphetamines and phenylpropylamine, nasal decongestants, etc., can also give rise to bleed. So this is the what I could find out from the Indian epidemiological studies. Common diseases which can give rise to young stroke in our nation is like cardioembolic, rheumatic heart disease, prosthetic heart disease, atrial fibrillation, bacterial endocarditis. Less common is MI and the related disorders. And infections are quite common, especially tuberculous meningitis is notorious to cause strokes. APLS syndrome is quite a common cause of stroke. And less common are the other vasculitis. And then atherosclerosis is a common cause because we know that with the obesity and the poor food habits and sedentary lifestyle, lack of exercise and all those things, even atherosclerosis can occur in the young age group. Dissection is a common cause and various rare causes are also there, which I'll not go into the details. Now intracerebral hemorrhage, I'll just touch upon it. So intracerebral hemorrhage, almost 14.2% occur in the younger age group. And these are the commonest causes which have been seen: ruptured aneurysm, ruptured AVM, hypertension in the young age group, eclampsias, especially in the pregnancy and the age groups. So these are the common causes. Now, if you look at the risk factors of ischemic stroke in young patients, 18 years to 55 years, if you look at that, this chart, this will show you that the most common risk factor for ischemic stroke is tobacco smoking. So smoking is the killer in young patients, and it is most of the strokes are associated with tobacco smoking. So stopping smoking is a very important intervention which should be started at a young age. Physical inactivity is the second most commonest cause. Hypertension in the young, dyslipidemia, obesity, diabetes, these are the other common cause, which is again seen in the elderly age group. So the common risk factors in the young age group and the older age group may be similar in a certain group. Only tobacco smoking is the thing which is more commonly seen in the younger age group. And physical inactivity, again, surprisingly, it's also common in the younger age group. Then the heart diseases are there, like coronary artery disease, congestive heart failure, myocardial infarction. Atrial fibrillation may also be seen in the younger age group. Other less documented but modifiable causes are: one is alcohol consumption. So alcohol intake is again associated with stroke. Migraine, you can see almost a lifetime, 27% of the other causes, migraine may be important cause. So always ask the history of migraine. Now, low sleep, less time, less than 6 hours. So poor sleep may be a risk factor for stroke. And a very important cause again is obstructive sleep apnea. We all know obstructive sleep apnea can give rise to excessive daytime somnolence. There is a high risk of nocturnal hypertension during obstructive sleep apnea, which can give rise to strokes. There is a increased chances of poor diabetic control in obstructive sleep apnea patients. And also it can give rise to various other manifestations like depression, anxiety, memory loss. So obstructive sleep apnea also you should screen in young patients who are having a stroke. Now, this I've already mentioned. It is important in developing countries like India because it has a very important economic burden and enormous consequences to the family and the nation. And we have seen that the average age of stroke in our country, developing country, is 15 years less than the developed countries. So it is quite common to have a young stroke in our region compared to the developed countries. So these are the various studies which has been done in India, epidemiological studies. And you can see there are studies from Vellore and all the parts of India, South India, and then Kashmir, Mumbai, Kerala. So most of the studies show that the prevalence is around, you can see 10%, some studies says 25%, even Jipmer, which is in South India, 36%, and 18%, 10 to 15. So average, you can see it's around, ranges from around 10 to 30, 35%. So average, you can take around 15 to 20% of strokes occur in the younger age group. So these are the various differential diagnoses. Cardiac disease, I'll just summarize again. So cardiac disease, large vessel atherosclerosis, vessel disease, which can be due to atherosclerosis, most important. Then dissections, which can be due to some inherited vascular problems like fibromuscular dysplasias or inherited metabolic diseases affecting the muscle wall. It can be due to infections, especially tuberculosis and syphilis. And syphilis is not very common in our place. Tuberculosis and herpes is another cause of vasculopathy. Then vasculitis, various primary vasculitis or secondary vasculitis like SLE, rheumatoid, Sjogren's, all these things can affect the blood vessels. Moyamoya disease, radiation, and illicit drug use. So these are the large vessel involvement. Now small vessel can be again due to infections, non-infections, etc. And diseases like Fabry's disease, which can give rise to small vessel vasculitis. Hematological disorders are a huge group of diseases. So we should keep this into mind, various diseases, and finally migraine. So this is the broad classification or differential diagnosis of a young ischemic stroke. Now, history taking in a young stroke is similar to that in the classical elderly stroke. So you ask the onset of the deficit. So most important thing is, when was the patient last seen normal? So that is the most important thing. That will give you a clue, because you know that the acute treatment of stroke is time bound. We have a window period of 4.5 hours for IV thrombolysis and up to 6 hours, and sometimes it may go up to 12 to 24 hours also for the mechanical thrombectomy and the various reperfusion procedures, which are now quite useful and has been found to be quite effective. So the onset of symptom is most important, and you should always try to find that out. Many a time the patient may be sleeping when the stroke occurs. So then it becomes quite difficult, and then you have to take the when the patient was last seen normal as the onset of the symptoms. And this is called as a wake-up stroke. So whenever you get a wake-up stroke, it becomes quite difficult because you do not know what is the onset. So in that case, you have to do additional investigations. You may have to do the MRI scan, and there are few techniques like the flare diffusion mismatch, which you have to see, and also the CT perfusion or the MR perfusion imaging, which may help you to find out whether the patient is a good candidate for a mechanical thrombectomy. Because if you see that the tissue is salvageable and there is a large penumbra which can be salvaged by doing the intervention, then irrespective of the timing, you go with the intervention. So now the concept of time is brain, which we thought before, like we should have time fixed management, has changed. Now we are looking at the tissue based management. So how the tissue is, so time may not be very, very important, because the collateral supply and circulation of the patients may vary from each other. So some patient with a good collateral may tolerate the stroke for longer period of time, and they may be having a large salvageable tissue even after 10 hours of the stroke. So in this patient, you can go for thrombectomy or the mechanical treatment, mechanical thrombectomy, even if the patient comes delayed into the window period. So the concept is, from a time window, we are going for a tissue window for the management of stroke. Now you have to look for the associated symptoms like headache, vomiting, seizures, neck pain. Rule out mimics like Tourette palsy, migraine, conversion disorder, and hypoglycemia. So these are the main mimics. Now there are a few studies which have looked at what will happen if you thrombolyze a mimic. So they have seen that it doesn't give rise to much higher risk of hemorrhage. So even if you are not very sure that it is a real stroke or a mimic, and you do not have the resource to do a MRI very urgently or very quickly, then you can thrombolyze the patient. So that is what the study says. Now the past history, you have to look for cardiac illness. You have to ask for migraine. You look for the systemic features of vasculitis like fever, joint pain, photosensitivity, skin ulcers, testicular pain for polyarthritis nodosa, limb claudications, upper limb for Takayasu's disease, abdominal pain for mesenteric ischemia, which can seen in polyarthritis nodosa. You look for oral ulcers, genital ulcers, red eye, which is seen in Behçet's disease. You look for hematuria, which can occur in various type of vasculitis, and also for the Zika symptoms for Sjogren's. Ask the history of manipulation or trauma in the neck. Very important. Many patients may have some trivial fall, or they may be going to a beauty parlor or a barber shop in which the neck may be manipulated for a massage, or some chiropractic maneuvers they may have tried for some neck pain. And this can all give rise to dissection of the carotid and the vertebral arteries. So that has to be taken, asked about. You ask the history of herpes, which may give rise to vasculitis. And you ask history of anemia with sickle crisis or pains, etc. visual problems, sensory symptoms in the limbs, and also snake bite, because viper bite can give rise to the various strokes. Bleeds and infarcts both may occur, so that we have to take history of that. And in the female patients, recurrent abortion, very important to rule out APLA syndrome. So at least you should have a 1 mid-trimester abortion, or there should be 3 first trimester abortions to say that it's a significant abortion. You ask history of other DVTs also, other venous thrombosis or myocardial infarction or other evidence of any venous occlusions in the past to rule out APLA syndrome. Syphilis is not very common in our part, and so genital lesions you should ask, and also generalized skin rash which occurs in the secondary syphilis. Tuberculosis, definitely you should ask cough and evening rise of temperature, weight loss, headache, cranial nerve palsies, all those things you look for. Abortion, DVT, and pregnancy, again I have mentioned. HIV is a important cause of vasculopathy, so ask history of exposure, especially in the young patient. Other vasculitis, bronchial asthma, chronic infections, otitis media, eosinophilia for Church-Strauss syndrome, HBsAg, HCV positivity in the past for polyarteritis nodosa or essential mixed cryoglobulinemia, bleeding disorders. Also collagen vascular diseases, ask for shoulder dislocation, bowel rupture, and spontaneous pneumothorax. So this can be seen in conditions like Marfan syndrome or Ehlers-Danlos syndrome, which can be associated with brain hemorrhages and various type of strokes. Drug history, very, very important, especially in young patient. Ask history of cocaine, amphetamines, IV drug use that may be related to HIV. Infective endocarditis may occur in IV drug abuse patients. Ask history of smoking and alcohol. Interferons, which is used in multiple sclerosis and various viral infections, chronic hepatitis, etc., can give rise to strokes. Phenylephrine, ergots, and bromocriptine can give rise to stroke. Antiplatelets, anticoagulants, and oral contraceptive pills, very, very important, because OCP is associated with cerebral venous thrombosis, and also it can, if OCP is used in migraine patients, then there may be a higher risk of stroke. So OCP use, this history has to be taken, especially in the young females. Family history, ask about stroke, cardiac illness, migraine, mitochondrial disorders, early diabetes, short stature, and retinitis, and hypertension and diabetes, etc., in the family. Okay, so you have done with the history, and now you go for the head to the foot examination. So few findings which may be helpful, like xanthilesmas, corneal arcus, which will tell you that the patient has a dyslipidemia or may be prone for premature atherosclerosis. Vasculitis in the eye may tell you that it may be a systemic vasculitis. This is an angioid streak, which may be seen with a pseudoxanthoma elasticum or Ehlers-Danlos syndrome, which may again tell that there is a collagen vascular disease. Lens dislocation in homocysteinemias. Then you may have various sort of vasculitic pictures. This is a hypopia and uveitis in Behçet's. Papilledema, this is a non-arthritic AION. So this is a non-arthritic AION, which can be seen in maybe associated with some vasculopathy of the retinal vessels. Then skin and joint, always look for hypermobility. You can see a very lax skin. You can see the cigarette paper scars here. You can see the blue sclera here, and also the pudy orange appearance, which is in pseudoxanthoma elasticum. So this may tell that there is underlying vasculopathy, and these patients may develop strokes, they may develop aneurysms, they may develop bleeds in the brain. Marfanoid habitus, always look for that. You can see high arch palate, arachnodactyly, the increased arm span. Then you can see the classical, this is the wrist sign, and this is the thumb sign. So this is also, wrist sign is called as the Walker-Murdoch sign, and this is the thumb sign or the Steenberg sign. So always look for that. Mitochondrial diseases may be associated with young strokes. So you look for the short stature, hearing problems. This is the midline lipoma. This is the hearing aid. Ptosis they may be having, and then retinitis pigmentosa. So these are the rarest causes: oral ulcers, erythema nodosum, genital ulcers, then nail pit infarctions, petechial lesions, purpuric lesions. So I have a detailed skin examination, and you can see the libido reticularis like lesions, which is seen with SLE, as well as there is something called as the Sneddon syndrome, which may be associated with strokes, the malar rash, and then certain conditions which can have telangiectasia. So you can see multiple telangiectasias all around. So this can also give rise to brain hemorrhages. You can look for nevus. This nevus may be associated with the brain, intracranial lesions in the brain, which can give rise to stroke. Drug abuse, tattoo marks. HIV, look for the candidiasis. This is the neurosyphilis, palm involvement, the syphilitic lesions here. And this is very, very important, herpes. So any herpetic lesions you should look for, because they are more prone for developing the corneal ulcers, also cavernous sinus thrombosis, and also they can get the vasculitis involving the brain. So look for the general examination, and then you go for specific examination. Look for pallor of plethora. Look for absent pulses, which is seen in Takayasu, or irregular pulses, which is seen in atrial fibrillation. Look for lymphadenopathy, organomegaly. Look for murmurs in the heart. And if the patient is febrile with murmurs in the heart and there is pallor, then it's likely to be infective endocarditis. Look for carotid and subclavian bruising and also peripheral pulses. If you don't get the pulse in one hand, or there is a asymmetric of the pulses in both the hands, then definitely look for the bruising. You can look for the carotid bruising as well as the just below the clavicle. You look for the bruising, because usually in Takayasu you will get a bruising all around. So that may give you a clue. You also look for the renal artery bruising if it's a Takayasu disease. And detailed neurological examination as per the protocol. So this is how you overall clinically evaluate the patient. Now you go for the investigations. Now you should know that the history, the examination, findings, and the history and the background history, everything will give you a clue and a provisional diagnosis. And with that, you are going to investigate the patient. Because in resource restricted countries like us, investigating the young stroke may be difficult. So every patient you cannot do the thrombophilia workup. Every patient you cannot do the vasculitic workup like ANA and C-ANCAs and all this, because it has a huge economic burden. And most of the patients will not be able to afford all the investigations. So with your clinical sense, with your examination and everything, and the basic investigations, you can plan out the further investigation and investigate according to the previous investigations, which based on the reports of the previous investigations. So doing the entire investigation together may not be necessary. You do the basic preliminary investigation, and based on that, you can plan for the further investigation. For example, hemoglobin and PCV you should do in all the patient. Eosinophil count can be done in all the patient. Peripheral smear you do. ESR CRP you can do. Peripheral smear if there is some abnormality, or if you suspect a sickle cell disease, you will do the sickling test, or HB electrophoresis. Renal function, liver functions, every patient you should do. Lipid profile should be done, especially if the patient is obese. Sugar should be done in all the patients. Even in young stroke, you do the sugars. Coagulation profile, if you're getting a bleed, you can do the coagulation profile. Lactate, if you are suspecting a mitochondrial disease. Urine routine, hematuria and cast, you look if you are suspecting a vasculitis. So if there are joint pain, rashes, you suspect lupus or some vasculitis, you should do the urine routine and the cast. Serology, HIV, HBsAg and HCV, again, wherever required, you have to do. And VDRL may also be done in patients if there is a history and if you're not getting the etiology of the stroke. Mantoux test and chest X-ray, if there is fever and cough and all those things you have to do. Now, cardiac examination is a must in all patients with young stroke. So you do a ECG and a 2D echo. And wherever indicated, and if you feel there is some endocarditis or some valvular pathology with the standard echo is not able to pick up, you go for a transesophageal echo. And if a simple ECG is not giving you results, you go for a Holter monitoring, and probably for a prolonged Holter of 2 to 3 days, and ideally 7 days would be quite optimum. And neck vessel Doppler should again be done in most of the stroke patients. Cardiac enzymes wherever required. Now, thrombophilia workup, if you find that the cardiac workup is negative and the vasculitis workup is again negative, and you've checked the carotids and all the blood vessels which are again normal, and if you think that the basic blood investigations are showing some abnormalities and you are suspecting a thrombophilia, then you go for the thrombophilia panel, which consists of protein C, protein S, factor V Leadin, antithrombin 3, and the APLA antibodies, and homocysteine also. So you do this. And vasculitis wherever required. ANA profile, C-ANCA, P-ANCA, and all those things. Pathergy test for Behçet disease you can do. Now, in young stroke, I'll suggest that all the patients you should do the MRI scan. So just do not depend on the CT scan, because MRI may be quite useful. It may give us some patterns which can help us in the diagnosis. For example, you look at CADASIL, there is a condition called as CADASIL, which is cerebral autosomal dominant leukoencephalopathy with infarct. So this condition, there may be a specific pattern in which you may get an anterior. I'll show you cases of CADASIL which I have. So I'll show you the imaging findings. So there are some patterns which may be helpful. Behçet disease, again, there is involvement of the thalamo and midbrain junction. So that is the classical site of Behçet disease, which may be quite useful. Tuberculosis, we all know there will be pattern, there will be basal exudates, there will be infarcts involving the deep penetrating branches and basal exudates, and although contrast enhancement may be seen, there may be granulomas. Okay, TB may, CT scan may pick up the findings, but if the CT is not picking up the findings, and if you see abnormal CSF is there, then it's better to do a MRI scan of the brain. Mitochondrial disorders, the MR spectroscopy may be helpful in showing us a lactate peak, and cavernoma will have a classical soap bubble, salt and pepper or soap bubble appearance, which may be quite useful for the diagnosis. Now, contrast, you should insist on doing the contrast in infections and vasculitis, because infections will show some contrast enhancement, and vasculitis may also show blood vessel enhancement, etc. Gradient echo, which is for looking for the blood, may be quite useful, especially in embolic strokes where there may be bleed. CVT may be, it may be a hemorrhagic infarct, so that may be useful. Vasculitis, there may be multiple microbleeds. CADASIL, there may be microbleeds. So you do the gradient also. Diffusion weighted, again, for the diagnosis of the infection, it may be useful. MR spectroscopy, I've already mentioned for mitochondrial. And you should do the T1 fat sat image, especially when you are suspecting a dissection, to look for the intimal flap. So that fat sat images will help us to find out the flap. Now, angiogram, again in young stroke, after doing the MRI, basic MRI, if you see there are abnormalities, and if you suspect any of these disorders like vasculitis, aneurysm, AV malformation, dissections, conditions like fibromuscular dysplasia, it's better to go for the MR angiogram. And MR venogram if you are suspecting venous thrombosis. Now, DSA may be very useful, and now it is seen that CT angiogram may be quite useful and even better than the MR angiogram. But if you are not, if you are unable to give a contrast, then you can do the MR angiogram. There are TOF images where contrast is not required, time of flight images. So that has the, and it's a non-invasive procedure. So MR angiogram may have advantage there. But usually CT angiogram is very good, and it is also cheaper than the MR angiogram. So it may be a very good alternative for the MR angiogram. And DSA and CT angiogram, it is seen that DSA has some more advantage compared to that of the CT angiogram. But as a screening tool, CT angiogram may be quite good. But DSA may be required when you are planning intervention. So suppose if you are planning for a mechanical thrombectomy, you have to do the DSA. If you are having a Moyamoya disease and you want to do some intervention, again, DSA is required. So DSA is the gold standard for the diagnosis, but CT angiogram may be quite an effective tool for screening of the young strokes. Now, there is something called as the arterial wall imaging. So now this is coming up in a big way, but it usually requires a high resolution scanner, almost at 3 Tesla, or a very well planned with good softwares. If you have a good M1.5 also you can do it, but usually 3 Tesla will be better. And it can tell you whether there is a atherosclerotic occlusion of the blood vessel or there is some vasculitis or some other pathology. But it has to be done under expert hands and experienced people, then only you can have a proper diagnosis. So arterial wall imaging is again a new thing which is coming in. Now, CSF study usually not required unless you are suspecting some infections like HIV, tuberculosis, or syphilis, or you are suspecting vasculitis like primary CNS angiitis. Now, primary CNS vasculitis is one condition in which the CSF may be abnormal, and malignancies like lymphomas and all those things, there may be having atypical cells in the CSF, which can be useful. And subarachnoid hemorrhage, occult bleeding sometimes can be missed in the CT scan, which a CSF study may pick up. So these are the indications of CSF study. Other indications like biopsy and all not required unless you are suspecting vasculitis. And genetic test again only required if you are having a proper diagnosis in mind And if the genetic condition is coming in the differential diagnosis list, then you can go for the genetic test, especially for mitochondrial disorders and CADASIL, where this specific gene is the Notch3 gene, which can be helpful in the diagnosis. So I think I've covered main things. Now I'll just quickly go through few slides. So congenital cardiac disorders, the risk factor of cardioembolic stroke in the perioperative period or following ECMO. So this, we are speaking about the congenital heart diseases which can give rise to stroke. So these are the mechanisms, that is paradoxical embolism, hyperviscosity. We have all seen congenital heart disease, there will be polycythemia. Then there is increased risk of infective endocarditis and septic embolism, and there is a propensity to thrombosis and arrhythmias. All this can give rise to strokes. For example, in this patient, you can see there is a cortical infarct here, and you can see there is a PFO here. So this is the PFO giving rise to the stroke. So diagnosis of PFO, patent foramen ovale, you should do a transthoracic or transesophageal echo with an intravenous injection of agitated saline. So along with the echo, you have to give an intravenous injection of agitated saline, and then you evaluate the patient at rest, Valsalva and cuff. And if there are positive bubbles, 3 or more appearing in the left heart within 3 cardiac cycles of bubbles filling the right atrium, that means there is a communication between the right atrium and the left atrium. So that is diagnostic of PFO. And you can also do a transcranial Doppler, which shows the bubbles in the middle cerebral artery. So these are the ways in which you can confirm a PFO. Now, what is the importance of PFO? PFO, these are more commonly associated with strokes, and the association is 5-fold more in the younger and 2-fold in the older age group, and prevalence is 25%. Now, the risk of embolism is more with the PFO size, the magnitude of the shunt, the tunnel length, and the concomitant atrial septal aneurysm. So if it's a large PFO and the tunnel length is very long and there is a atrial septum aneurysm, then there is a high risk of stroke. So these are all characteristics we have to find out and then decide whether we are going to close the PFO or we are going to operate on the PFO. So this is a score which is called as the ROPE score, which is helping us to find out what is the risk of the embolic stroke due to PFO itself. So you score this patient, whether there is hypertension, diabetes, prior history of TIA, smoker or non-smoker, what is whether there is a cortical infarct in imaging. So you score this and then you find a score. So if the maximum score is 10 and minimum score is around 0. So more the score, the more the chances that the stroke is due to the paradoxical embolism due to the PFO. So this score can be used in practice, and this is the management protocol of PFO. So if you get a PFO, then you look at the age of the patient. If more than 60 years, you go for an antiplatelet therapy. If it is 18 to 60 years, then you look at the PFO, whether there's an aneurysm, what is the septal tunnel length and all those things. And then if there are poor prognostic factors, then you close the PFO and give antiplatelet along with that. And if not, then you continue antiplatelet treatment only. Now, this is a common scenario: patient present with fever and uncontrolled fevers. We don't know what is the cause of the fever, PFO. There may be joint pains, there may be skin lesions like this, and you see the vegetations here, and there may be large stroke. So this is called as an infective endocarditis. Now, endocarditis is very important to diagnose, because in endocarditis, you should not thrombolize the patient because the chances of a hemorrhage is quite high. So this is one condition where you avoid thrombolysis and you treat with antibiotics. Then this is a atrial myxoma. You can see a large lesion here, atrial myxoma, giving rise to the stroke. And you can see there is a dense MCA sign also here. It's a MCA dot sign rather than MCA dot sign, which is the thrombus here, which has migrated from the heart. Now you're coming to the vasculitis. Vasculitis, it's a large group, and we know there are infectious vasculitis, and then classical vasculitis, secondary vasculitis due to collagen vascular disease, etc. We'll not go into the details. So tuberculous meningitis is a very important cause of vasculitis. You can see here. So this is the brainstem, this is the midbrain butterfly shaped structure, and then you see there are multiple exudates bilaterally. So these are all contrast enhancement and exudates. You can see granulomas around, and you can see there is, due to the exudates, what happens is the blood vessels becomes inflamed, there is vasculitis of the blood vessel, and there is occlusion of the blood vessel, giving rise to strokes, extensive strokes. So actually we have to prevent this complication. So how will you prevent this complication is by early diagnosis. So whenever a patient has a fever, headache, and diplopia and all those things, then immediately you should do the imaging and do the CSF and diagnose tuberculous meningitis early on, so that the patient does not go for this complication. Post-herpetic vasculopathy, you can see there is a facial deviation, and then later on there is a stroke, large stroke involving, there's a diffusion restriction here, and you can see there's the right MCS cutoff. So this is a post-herpetic vasculopathy. There are two types of post-herpetic vasculopathy. One is a large vessel and a small vessel involvement. Now, if it's a large vessel involvement, the MRI will show stenosis, and if it's a small vessel involvement, the MRI may be normal. This we have to remember. So this is one patient which I had years back. So you can see there is a rash on the face, and the patient developed altered sensorium. You can see multiple hemorrhagic lesions. So this was a vasculopathy, and the angiogram was normal in this patient. You can see the angiogram is normal. So it's a small vessel vasculopathy which is occurring in the multiple territories due to herpes. Then syphilis again can give rise to stroke, but very rare nowadays. You can see multiple infarcts, vasculopathy, and skin lesions. So always, when you get a large vessel infarct, and if you're not sure about the cause of the stroke, always do the CSF VDRL, because that will give you a clue regarding whether it's a secondary syphilis or not. Secondary or a neurosyphilis with stroke. So usually it occurs later on, usually in the tertiary stage, you'll get the stroke. Now vasculitis, we all know large vessel, medium vessel, and small vessel. And the large vessel is Takayasu and giant cell arteritis. So both of them can give rise to stroke. Takayasu occurs in the younger age group, less than 40. Giant cell arteritis occurs after 50 years. So elderly patient coming with headache, coming with stroke-like symptoms, with jaw claudication, pain in the hands and the limbs, in the proximal girdles, polymyalgia rheumatica, has fever, has pallor, is feeling very tired, there is weight loss, then you suspect a condition like temporal arteritis or giant cell arteritis, and you may get a tender swollen blood vessel or a non-pulsatile temporal artery, so which may be a clue for temporal arteritis. So it's again a very serious disorder, and there may be visual loss, so you have to diagnose the patient as early as possible. Takayasu usually occurs in younger females, and usually they present with limb claudication, and when you examine, the pulses may be absent and there may be asymmetrical blood pressure. So these two conditions can give rise to stroke. And medium vessel Kawasaki's and PAN may also give rise to stroke, and small vessel, usually the stroke-like presentation are quite rare in this condition. So you can look at this Takayasu disease, you can see there is involvement of the blood vessel. So you can see there is the right subclavian artery onwards, there is occlusion, and also involving the renal arteries. HBsAg patient with multiple stroke-like vascular lesions. There are large punched out lesions in the legs, and there is a digital gangrene, dry gangrene, and there are microaneurysms involving the abdominal circulation, mesenteric circulation. So this is classical of polyarteritis nodosa. It's a difficult diagnosis to make because it is ANCA negative. So neither P-ANCA or C-ANCA is positive. So there is no serological marker for this condition, and you have to see the clinical features, and then maybe a mesenteric angiogram showing aneurysms and a biopsy will give us a clue that it is likely to be a polyarteritis nodosa. And Behcet disease, I have already mentioned, it's in the midbrain lesion, oral ulcers, and this is the classical pathology test in which you prick with a needle and then look for a vesicle formation at around 48 hours. Now this condition you should remember, because this is one condition which can give rise to ischemic and venous infarcts also. Arterial and venous infarcts both may occur in this condition. The other condition which can give rise to arterial and venous infarct is APLA syndrome. So these two conditions you should remember. Now this is a very difficult diagnosis to make. It's called as primary CNS vasculitis. So usually occurs in the middle age people who come with refractory headache. They can present with stroke-like episodes. They can present with dementia, cognitive decline, memory impairment, and all. And there may be multifocal white matter lesions. When you do the MRI, there may be multifocal white matter lesions with there may be microbleeds in the MRI, which will tell you that it's likely to be a vasculitis. Angiogram may show there is evidence of vasculitis. So such patients, and there is no evidence of any systemic vasculitis. So the ESR is normal, the CRP is normal, there is no joint pain, no peripheral vasculitis, only vasculitis which is confined inside the brain vasculature. So that is called as a primary CNS angiitis. So in this patient, you have to do the DSA to look for the beading, which is seen here. You can see multiple beading here. And also you can do the biopsy. So there you have to do the leptomeningeal biopsy for diagnosis of this condition. This is a life-threatening condition, and you have to treat the patient immediately with induction therapy, cyclophosphamide and pulse methylprednisolone, and maintain the patient on long-term immunosuppression to save the life of the patient. Now there is a condition called as RCVS, reversible cerebral vasoconstriction syndrome. It is seen in the pregnant patients mainly, and it can be seen in non-pregnant patients also. It's also called as Coll-Fleming syndrome. Okay, so the classical syndrome symptom of this condition is thunderclap headache, and the thunderclap headache is multiple in nature. So there will be recurrent thunderclap headache which occurs. It is usually induced by some condition like pregnancy or taking a hot water bath or some heavy weight lifting, etc. Any condition or drugs, medications can trigger this condition, and the patient will have a recurrent thunderclap headache, and there may be some. This is called as a subarachnoid hemorrhage. So this is a convexal subarachnoid hemorrhage. So if you get a convexal subarachnoid hemorrhage with a thunderclap headache, then it is likely to be RCVS. While in a aneurysmal subarachnoid hemorrhage, it is usually not convexional. It occurs in the lower part, and usually you will have a one attack of thunderclap headache rather than recurrent attack of thunderclap headache. And when you do the angiogram, you can see here there are multiple occlusions here. All around there are occlusions. But after 12 weeks, when you review or repeat the angiogram, you can see the blood vessels have opened up. So in this stage, it will look like a vasculitis. But when you repeat the angiogram after 12 weeks, it is reversible. So that's why it's called as a reversible vasoconstriction syndrome. And it is a differential diagnosis of CNS vasculitis. Now, this is Susac syndrome, which is you will get a retinocerebrocochlear syndrome where you will be having retinal branch, retinal artery involvement, and also multiple stroke-like episodes with hearing loss in a young patient. So that is called as a Susac syndrome. Now, APLA syndrome, already I have mentioned, multiple arterial venous infarcts. And you should always know that in APLA syndrome, it may mimic an infective endocarditis. So there may be some lesions, vegetations in the valve, and that may give rise to, it's a cause of non-bacterial endocarditis. And it may give rise to venous infarcts also. So this is the deep vein which is involved, and you can see there is bilateral edema involving the thalamus. So this is an important cause of bilateral thalamic edema. The differential diagnosis may be ADEM, acute disseminated encephalomyelitis. So in a young female with oral contraceptive pill suddenly becoming unconscious with headache, papilledema and all, you look for a deep venous thrombosis. So, and it can also occur in APLA syndrome, which has to be kept into mind. Now, this is arterial dissection. So history of trauma or without trauma, presenting with neck pain, and there is a ptosis and neck pain and headache, always think of a dissection. So you can see this is the T1 fat sat image, which I've already mentioned. You can see this is the internal carotid artery here, which is normal. You can see the lumen well seen, but you can see there is a thrombus inside the lumen with there's a margin here. So this is called as the flap of the dissected artery. So this can be found out with the T1 fat sat image, and also you do the angiogram, which will show you the dissected part. So this is called a cervical artery dissection. So this can be spontaneous also. So we should know that dissections can be spontaneous, and sometimes there may be an underlying connective tissue disease like Ehlers-Danlos, Marfan's, etc., which may go for a dissection of the blood vessels. So this is the internal carotid artery dissection. You can see there's the subintimal flap, and later on, initially there is a dissection. There will be initially neck pain and some headache and some ptosis and all may be there, and later on there is thrombosis involving the dissected artery, and then the patient develops a stroke. So usually the stroke will be a bit delayed in a dissection. And there may be aneurysm formation also sometimes, pseudoaneurysm formation. Now, vertebral artery can also be dissected. So you can see there is this is the vertebral artery in the right side, and left side you can see there's a non-visualization of the vertical artery, and you can see a stroke which has developed here. So any lateral medullary syndrome and brainstem stroke, if there is neck pain and history of some manipulation or trauma, always suspect a vertebral artery dissection. And now the treatment is usually by anticoagulation with heparin and continued and followed by warfarin for 6 months. Now you should know that surgical repair is required if there is pseudoaneurysm, etc., or if it is not responding to medical management. But if there is an intracranial dissection along with extracranial dissection, you should avoid anticoagulation because the subarachnoid hemorrhage can occur. So only extracranial dissection you will give anticoagulation for 6 months. Now this is a fibromuscular dysplasia, very rare condition. I don't think I've seen any patient, but young child with renal failure and accelerated hypertension and stroke, you should think of this rare condition. And you get the classical string of bead appearance in the fibromuscular dysplasia. You can see here. Now history of radiation and then patient develops stroke later on. You can see there is occlusion of the blood vessels of the circle of Willis, and there are multiple collateral formations. So this is the puff of smoke appearance, and then they usually present with bleeds. And initially they will have infarction because initially there is occlusion of the blood vessels, so the blood supply is reduced and they develop infarction. And one more important symptom of moya is crying or hyperventilation induced TIA. So whenever they cry or they hyperventilate or they breathe very fast, they develop TIA-like symptoms. So that may be initial clue, and they may develop ischemic strokes initially, and later on when the collaterals become huge and they are quite weak collaterals and the walls are very thin, they may go for intercerebral hemorrhage. So these are the various causes of moya, multiple causes are there. And moya disease is the classical one, while this is the moya syndrome, which has a multiple classes. So there are various gradings of the moya disease. It's called as Suzuki's arteriographic gradings. I'll not go into the detail. And you should know that the ischemic moya you treat with platelet anticoagulants, antiplatelets you use, and then also vasodilators and calcium channel blockers may be tried. Steroids no role, and surgical revascularization has to be done. Now coming to focal cerebral arteriopathy, which is a common condition which is emerging in the childhood, and usually they'll have non-atherosclerosis, unilateral focal arterial stenosis. So this patient I have already presented first case. So there are two types. One is a dissection type and second is an inflammation type. I'll just rush through this. Now there is one interesting condition which is called as ADA2 deficiency. It's called as DAD2, DADA2 deficiency. So this is a condition which presents with childhood stroke and usually mimics a polyarteritis nodosa-like picture. And this is one journal case which I could find out. There are multiple skin lesions, and this patient usually present with infarction as well as bleed. So both type of strokes may occur in this condition. And these are the various manifestations of the deficiency of adenosine 2 deaminase this. So they will be having immunodeficiency, though they are more prone for infections, bacterial infections, and all those things, bone marrow problems. Cytopenias may occur, and there may be having multiple manifestations. So whenever you have such systemic symptoms along with stroke and all those things, always suspect this condition called as DADA2. And usually they'll be having hepatosplenomegaly, recurrent fever, weight loss, and also it may look like some infections. And also this condition has to be suspected in the, it's a rare condition, but it is quite seen. And in Chandigarh, in India, there are a lot of case reports of this emerging condition. And there are other rare conditions also like Caracel, fibromuscular dysplasias, which I've also mentioned. There is something called as face syndrome, in which you may be having posterior fossa malformation, which can give rise to stroke. There is something called as a Bow-Hunter syndrome or rotational vertebral artery syndrome, in which there is symptoms of brainstem or cerebellar ischemia around the V3 segment on physiological rotation of the head. So when the patient rotates the head to one side and extends, there may be a TIA-like symptom. So such things, you think of a dynamic compression of the vertebral artery. Now, drug-induced stroke I've already mentioned. Infarcts and bleeds both can occur. And this is the condition which is called as CADASIL. So you can see there is a classical involvement of the anterior temporal lobe and the external capsule. And these are the classical curvilinear bodies which you see in the skin biopsy. And this is a Notch3 gene which is responsible for the CADASIL. Now I have two patients which are under follow-up, mother and son. both of them having CADASIL. You can see the multiple extensive infarct. So this is a young boy, a young man, almost 35 to 40 years, and the mother is around 60, 70 years, and she is having full-blown lesions, multiple lesions, and you can see the temporal lobe involvement. And the son just had a TIA, but the MRI is showing there are multiple lesions. So he is probably going to develop the full-blown picture. And this lady, the mother, has dementia, memory loss. She's having features of vascular Parkinsonism, gait abnormality, and all those things. While the son is asymptomatic with just one episode of TIA, but you can see the MRI picked up multiple lesions, suggesting that both of them are having CADASIL. And mother has been tested for the Notch3 gene, which is positive. Son, since the MRI is corroborating, we did not go for the genetic study. So now this is MELAS. MELAS, again, you will have multiple lesions. Now you see there are large lesions which are not confined to the vascular territory. So if you get lesions which are not confined to the vascular territory, you think of conditions like MELAS, or you think of a venous infarct, which again do not go for the vascular territory. And you can see there is a lactate peak here. And sometimes basal ganglia calcification may be seen in the CT scan in MELAS. So this again shows the MELAS-like syndrome. Now, Fabry's disease, you get the skin lesions. It's called as angiokeratomas in the chest, and you get the corneal abnormalities, and you get multiple stroke-like lesions, and also renal involvement. So there is renal failure also. If you get multiple system involvement and small fiber neuropathy. So these are the classical manifestations of Fabry disease. Very rare condition, but it's a treatable disorder because there's an enzyme replacement which is available now. Now going to migraine, this is the classical aura of migraine. You can see there is a spot here with a colored thing here. So migraine can give rise to strokes as well. Usually the strokes are in the posterior circulation, and 3 times higher risk of stroke is there in the migraineurs, and also carotid artery dissection and PFO may be associated with migraine. So this can again increase the risk of stroke. So these are the various mechanisms, and especially the migraine with aura and the subtypes of migraine like hemiplegic migraine, basilar migraine, and retinal and ophthalmoplegic migraine can give rise to stroke. So when do you suspect a migraine related stroke? Young female, high risk migraine subtype, especially smoker with migraine. Be very careful. Migraine patient on oral contraceptive pills, high risk of stroke. And onset is usually typical, followed by severe migrainous headache, and there may be prolonged aura before the onset of the stroke-like symptoms. And posterior circulation is usually involved. So you should just highlight this point. If there is smoking along with migraine, there is a 10-fold increased risk of stroke, and combined with oral contraceptive OC pill with migraine, 17-fold. And if the patient is a migrainer with smoking and OCP, almost 30-fold higher risk of stroke. So all migrainer patients with aura, tell them to avoid oral contraceptive pills and not to smoke. Even females do smoke, so you should ask them strictly not to smoke because that will increase the risk of stroke. So this is one patient with migraine which I had. So you can see there is a small stroke involving the right upper part of the thalamus or the lower corona radiata, you can say, and then there are no risk factors. Workup is entirely normal, so probably it is related to the migraine. Hematological conditions, sickle cell can give rise to stroke, I've already mentioned, and polycythemia rubra vera. So this is one condition which can give rise to stroke, and you can see there is redness of the hands and feet, which is called as erythromelalgia. So two systemic symptoms of polycythemia, we all know there is hyperviscosity symptom, there may be tinnitus, there may be headache, there may be plethoric eyes, there may be erythromelalgia, that means burning sensation and pain in the extremities. And a classical symptom is aquagenic pruritus. So whenever they take a hot water bath, they get the classical pruritus. And hyperuricemia, peptic ulcers, joint pains, and all those things may also coexist. So whenever you get this symptom complex, then you think of an polycythemia, and ask history of smoking also, because that may be the commonest cause. So I had a case before, polycythemia rubra vera, which presented with a stroke. And when we evaluated, the hemoglobin was very high, around 17.5. And then we did the JAK2 mutation, which was again detected. JAK2 mutation was found to confirm polycythemia rubra vera, treated with hydroxyurea and also with phlebotomy and drainage of the blood. And few patients with proteinase deficiency which had stroke, multiple stroke. So protein S deficiency, 2 patients with stroke. So these are the various causes of acute stroke. Now the treatment I've already mentioned, you thrombolize the patient if more than 18 years, non-pregnant, and there are no contraindications. And premature atherosclerosis, antiplatelet statins, and risk factor modification as in the elderly patients. Then infective causes, ATT with steroids if it is tuberculosis, meningitis, with or without antiplatelet. Whether aspirin should be given or not is not clear. Herpes, you have to give acyclovir with steroids initially. Syphilis, injection benzodiazepine. Cardioembolic stroke, you give anticoagulation. It's a valvular involvement or rheumatic heart disease. Warfarin should be given. If it's a non-valvular pathology, you go for Novax if the patient is having atrial fibrillation. PFO, if there is atrial septal aneurysm or a high flow, you do give a device closer. Otherwise, you go with aspirin. Infective endocarditis, you give antibiotic treatment. Now, for the venous strokes, APLA, protein C, protein S with venous stroke, lifelong anticoagulation is required. If there is recurrent CVT, again, you have to give indefinite anticoagulation. Otherwise, for pregnancy and purpurium, where you are having a provoked CVT, 6 months of anticoagulation is enough. Unprovoked CVT, you go for 1 year of anticoagulation. Sickle cell acute infarct, you go for exchange transfusion and hydration of the patient. And you prevent the infarct by keeping a HBS less than 30%, repeated transfusions, and you can use the transcranial Doppler, which can help you regarding the management. And also hydroxyurea may be useful for sickle cell. Polycythemia, phlebotomy, hemodilution, and chemotherapy, hydroxyurea and other medications with the help of the hematologist may be started. Vasculitis, I've already mentioned, high dose steroids, cyclophosphamide may be used. And dissections, anticoagulation if it is extracranial, intracranial, usually you avoid anticoagulation. And pseudoaneurysm and other things, you go for angioplasty and stenting. Operative procedures may be required. Now, moya, there is something called as a encephaloduro-arteriosyngiosis or encephalomyoarteriosyngiosis, where you connect the temporal artery with the MCA and then so that the circulation is improved. So this surgical revascularization techniques may be used. Inherited disorder, if it's a mitochondrial disorder, you go for the mitochondrial cocktail, where you use coenzyme Q, thiamine, carnitine, folic acid, L-arginine, all this can be used. And Fabry disease, enzyme replacement, though very expensive, is now available. So final few slides, we know that young stroke, the prognosis is better, but it may not be benign. And it was seen in various studies that 8% of the patient died, 3% from another stroke, 3% had myocardial infarction, and 16% were dependent even after the stroke. So though they have a better prognosis, there may be a lot of disability, mortality associated with that. And the outcome is better, I've already mentioned, because of good collaterals as well as good neuroplasticity. And the undamaged areas can frequently assume the function of the damaged areas. And sometimes the patient may improve totally after the stroke. So we should start the treatment and manage them as early as possible. Now, take home messages, it has a huge economic impact and increasing with the change in the risk factor profile, should be investigated properly for the etiological diagnosis. Maybe an initial pointer to a deadly underlying disease. Treatment depends upon the etiology. Prognosis is usually good and prevention is the key. So you have to prevent the stroke by proper risk factor management, ask them to stop smoking, maintain a proper body weight, do regular exercises, avoid alcohol. And these all basic things may be quite useful, especially in the premature atherosclerosis group of the young stroke. So that is all.